All right. Well, welcome everyone to today's industry seminar from the Harvard Data Science Initiative. I'm Jen Chow. I'm Director of External Engagement for the HDSI, and I'm pleased to introduce our speaker today, Peter Smittenaar from Surgo Ventures. So Sergo Ventures is a nonprofit 501c3 organization focused on solving health and social problems with precision. It combines a diverse team of data scientists, behavioral scientists, and technologists to integrate approaches from multiple disciplines to develop hyperlocal, data-driven insights and solutions that can be implemented and scaled at all levels of policymaking. Peter Smittnar is Director of Data Science and AI at Surgo, where he works with an exceptional team of data scientists from a range of disciplines to generate new solutions to persistent global development challenges, and more recently, COVID-19. Prior to Sergo, Peter joined a seed-funded startup called Hinge Health as principal data scientist and clinical researcher, and has advised several other digital health companies. He also worked as science lead on Cancer Research UK's crowdsourcing team, helping cancer researchers analyze image data through citizen science. Peter has a PhD in cognitive neuroscience from University College London, as well as an MSc in cognitive neuroscience and BSc in molecular biology, both from Radboud University in the Netherlands. So before we get started, I want to remind folks that we use the Q&A function in Zoom, so feel free to pop questions in there for Peter during his talk. And with that, I will give the floor to Peter. Welcome, Peter.
Thanks, Jennifer, for the introduction. Just share my screen here. Yeah, and as Jennifer already said, if there's any questions, do post them. I'm happy to take some. Otherwise, I'll just be talking to my screen for 45 minutes. So, yeah, first of all, thanks for inviting me. It's great to be here. Great to be given the opportunity to talk about our work at Surgo. Yeah, like I said, we'll be talking about applied data science for global health, but particularly for COVID-19. And I'm going to give you a bit of an impression of the kind of work we do, the kind of data science, and also how this might be different from working, say, in a tech company or in academia. Jennifer already explained a bit of this, but to go into a bit more detail, Surgo Ventures is a nonprofit. We're a fairly small organization, and our mission is to bring precision to solutions that save and improve lives. And that word precision is important, and that's a common thread through all our work. It's really about moving from one-size-fits-all solutions to solutions that are tailored to individuals, the environment the person lives in, and so on. We have a range of experts on board to make that happen, and our focus is on behavioral science, data science, and AI. I'll give you a brief timeline just to give you a sense of the sort of problems, initiatives, and tools that we work on. Sergo was founded about 6 years ago, really more as an experiment. So instead of considering people that we're trying to help as passive recipients of our aid, can we treat them as customers instead? Right? Customers make choices. They are influenced by their beliefs, the social structures, the people around them. They have particular risk perceptions. They live under particular laws and policies. They have particular incentives. And the idea is really, can we use behavioral science and data science to understand the full picture and the system that these individuals live in, to then deeply understand their choices and better understand how we can help. And like I said, it's the tools from behavioral science and data science that play a critical role here. And the solutions that we come up with, we try and scale them by working very closely with our partners, which I'll talk about shortly. So most of our work can be divided into initiatives and tools. So initiatives are projects that we work on with our partners, and tools are things that we develop in-house. Really, Surgo started in India, in the state of Uttar Pradesh. The focus there was on mothers and newborns, and understanding, again, the decisions they make, the pressures they face, the barriers they face to healthcare, by not just understanding them, but also the facilities that they attend, the nurses and doctors that work there, the community health workers that provide support on a week-to-week basis. We did that through surveys and experiments. And really from that work, we arrived at a behavioral framework that we've coined cubes. And the idea is there, if you take any behavior, like say a mother deciding whether to go for a delivery in a facility or whether to deliver at home, or someone deciding to take a COVID-19 vaccine or not, can we systematically map all the factors that play into that decision, right? What are the drivers and the barriers to the decision? And the cubes framework is we really use it throughout our projects to more deeply understand and systematically map those factors. We extended our work in India into sexual and reproductive health, understanding family planning. Why do people use family planning methods or not? What are the barriers there? That was in a neighboring state in Madhya Pradesh. So also in India, we worked on tuberculosis, care seeking. So again, people might have symptoms of tuberculosis, but then they don't always go to a doctor, right? So their symptoms worsen, they're infectious, treatment becomes more costly, and it's just detrimental to the health of the individual and the people around them. And again, it's not just a case of, oh, we need to build more facilities, right? We just need to improve the supply of healthcare. These people make decisions and they have risk perceptions and ideas and barriers that go far beyond that. So again, we're trying to understand that complex system and find interventions to improve care seeking. We worked in Uganda and India on digital tools and particularly around community health workers with the government and with other nonprofits. This is, the causal machine learning is a strand of work that's run for several years now, where we're developing tools and algorithms. This is in Python, but also the algorithms in the environment to do Bayesian causal networks for observational data. And we're working on case studies around that, but we have a substantial piece of software now that can do that. And we're looking to introduce that across our work because it helps get at these causal factors of behaviors that we care so much about. We launched an initiative working with several governments to understand how data science and AI can help them. Did a pilot project looking at satellite imagery to try and predict health outcomes. And also, this was in the US, Rides for Moms is a partnership with Uber to provide free rides to antenatal care for certain mothers. But of course, then COVID hit, and some of these best laid plans were laid to waste, and we really pivoted to COVID, and we'll be talking about that for most of the rest of the talk. I think what's interesting about Surgo is that we really seek to partner with large organizations. So we're small organizations. We don't go out and build our own app or set up our own health facility. We have our expertise. We're good at that, but then we partner with governments, foundations, other health organizations that are working on the ground, or even tech companies, and we bring our expertise in, and that's how we have impact at scale. So a lot of our time is really spent building and fostering these relationships. And we have a great team of not just data scientists, but also program managers, communications experts to help with all that kind of work. But the data scientists play a key role in building that infrastructure, of course, doing some of the actual work in terms of the data, but also setting up these relationships, building credibility, and doing all that work to make it successful. So like I said, we're not a tech company, we're not a product company. This most closely resembles a kind of consulting structure where we drive impact by working with these partners. And the outputs of our work, other than, of course, all the conversations we have and the reports and the slide decks, we still publish peer-reviewed papers. We go to conferences on machine learning and data science. We also raise awareness and shed light on certain issues. We might do that through the press and media. We put out public reports. So that's kind of the range of outputs that we have. Really anything to drive the impact that we're looking for. And just very briefly, the team is, the organization really started in DC, and that's where most of us are. We now, with COVID, have gone a little bit more remote. So we have one person in New York, one in Toronto. I'm in the UK, and there's a few more of us in the UK as well, because we have a UK portfolio. And then we have a team in India and working on our various projects there. And like I said, it's a mix of data scientists and non-technical people as well. And Jennifer already told you about this, but just very briefly, my background, did a PhD in neuroscience and got really excited about crowdsourcing because we released this application called the Great Brain Experiment. And this was really the first kind of gamified psychology experiment. So this was back in 2013. You could play little games on your phone, and there were psychology experiments. And this got about 150,000 users fairly quickly, which was a world apart from what we normally do, which is we'd analyze data from 20 or 30 people from the lab. So this really got me interested in the potential of crowdsourcing citizen science. So that's what I did at Cancer Research UK, which is the major cancer research funder. And there was a science lead working with researchers who had all this image data, but no one to analyze it. So we set up applications and projects where the public could help analyze these kind of data. And I moved on to my next role, which was not a Burger King, but we were in these offices just above, if you can see these windows here. So it was a little startup with 7 or 8 people, and I was the only and therefore principal data scientist and also clinical researcher. So supporting our product teams and software developers and teams with various analyses, but also understanding the effectiveness of the product and analyzing the user data from 50 or 100 people that we had at the time to make sense of what was happening. Sorry, I should have said that. That was Hinge Health. You can also see the for sale sign there on the windows. That's because they're now in San Francisco and recently were valued at 3 billion. So they've done very well for themselves, which I'm really pleased with. And then about 3.5 years ago, I joined Sergo. Okay, so let's talk about some content. So COVID-19 in March of last year, we decided to really switch about 90% of our work to develop tools and insight to support the COVID response. And this is a kind of high level overview of some of the things we've done. It doesn't cover everything, but it covers the majority. So we constructed vulnerability indices for the US and for Africa. And we'll spend a good chunk of time talking about those. And then on top of these indices, we build a toolkit where we're partnering with lots of entities across the US to really guide US policy based on the data that we've put together. And not just the index, but also a whole range of dynamic data sources. So things like where are test sites being located, and where what's mobility like, where are people wearing masks versus not. So we have a lot of secondary data that we can combine with our index to provide a very rich picture to guide US policy. We also partnered with a company in Africa to provide a free symptom checker for people for COVID-19, where even without a smartphone, you could just dial in for free to a number and kind of triage your symptoms, which is, we've, it's been really great because it's been a very popular service. So it's allowed us to gather all the data, but also just provide a useful service for people that otherwise wouldn't have access. And then what's keeping us very busy lately is our COVID-19 vaccine portfolio. And this is pretty mature at the moment in the US, and we're also developing a portfolio in the UK and to some extent in Africa as well. Okay, so the Community Vulnerability Index. So by index, by the way, for those that don't know, this is like, it's a map with scores on it, basically, for different regions. And we're trying to map vulnerability, which is the expected impact of COVID-19. But I'll tell a bit more about that. So why did we decide to develop an index in March? Well, in mid-March 2020, there was a tiny number of positive tests per day, only 400 across the entire US. But that was largely because there just wasn't the testing capacity. Already it was known that there was a lot of community transmission, and later modeling would show that about 160,000 people were walking around infected with COVID, even at that time. So there were a lot of people working on these forecasting models. And for those of you familiar, these are these epidemiological models, these SEER models, and they were providing pretty dire projections, honestly. And this was the New York Times at that time. There was shutdowns across Europe. And already there was this awareness that it was going to have all these secondary effects on the economy and businesses. And given that the virus is widespread in the US already, we figured, well, first of all, we weren't epidemiological modelers, so we weren't going to be able to contribute a lot there. But also, if COVID was going to hit everywhere and it was going to reach every community, then to what extent can we get ahead of that, and where can we start mapping where we expect the greatest impact? Not just in terms of the COVID-19 impact on hospitalizations and deaths, but also in terms of the social and economic damage. So this proved to be a cornerstone of our US work, and the index maps who these most vulnerable people are in terms of the health, social, and economic impacts. It helps map why they're vulnerable, because 2 vulnerable people could be vulnerable for very different reasons. And this has helped put together a toolkit for the partners that we work with on how to respond. Now, the way we started with this is we started actually with the CDC social vulnerability index. This has been around for 10 years, and it's an index that isn't specific to any one virus or one type of disaster. It's a generic index for any type of negative event, whether it's human-made or a natural disaster like a flood or a fire or a hurricane. Now here, this is a map of the social vulnerability index. These are counties in the US. There's about 3,000 of them. But it's based on census variables, and census variables is very granular data. So here, looking at a county in this outline here, and there's also census tract data, which is much more granular. There's about 70,000 of those across the US. And this social vulnerability index just takes these 15 indicators, groups them into 4 categories, and creates a composite score so that every region is ranked from high to low relative to every other region in the country. So here, for example, socioeconomic status. Are there a lot of people that are unemployed or low income? Household composition, things like, are there a lot of children or a lot of elderly? Are there a lot of people that are disabled? And race and English as a second language. So there are a lot of minorities or people that don't speak English very well. And housing and transportation. Right? Are there a lot of people that live in very crowded housing or don't have a car, for example? So this index was already quite well known among public health people, and it's really garnered steam throughout this pandemic as well, but it wasn't COVID-19 specific. So, when we decided, okay, we want to build an index, how are we going to go about it? We decided to go with the SVI for the main reason that it was very well validated and it was also readily available, because we wanted our index to be credible, right? And people knew about the SVI, the Social Vulnerability Index. And it was also available so we could build on top of it. So it'd be much faster. And of course, it's not maybe as elegant as starting from scratch, but this really proved very useful, because in a matter of weeks, we were able to put this index out and make it available. We also took a fairly practical approach, right? So some people build these indices by taking all the indicators and using the statistical properties to construct an index. For example, you can do principal component analysis or factor analysis, or you can do some canonical correlation analysis, which just groups indicators in a purely data-driven way, right, with no concepts on top. But because this index was targeted to people working in health departments in the States or at the federal level, and it's supposed to be a very practical index, so we wanted themes that made conceptual sense and were within a particular theme. So that's why we grouped indicators based on those themes rather than their statistical properties of the indicators. Another point is that, and this was, I think, is a big one, is that this is a static index, right? So there was a lot of people have been doing modeling and, for example, tracking where hotspots are or forecasting where they're going to be, or these epidemiological models, and they're immensely useful. And this is really a complement, a vulnerability index is really a complement to that. So we're mapping the underlying drivers of vulnerability. So for example, if one of your forecasting models says, these 2 regions are going to have a really high rate of infections, but one is vulnerable because of socioeconomic reasons, and the other because of a health system which is weak in that region, for example. That warrants very different interventions. Right? So if you're telling all the people that are very poor to stay at home, that's going to really hurt their income, ability to pay the rent, provide food for their families, etc. Whereas in the case of the health system, you might want to strengthen the health system, add more beds, set up transport to other counties, etc. So we really see the static index like that as a very useful complement to these other models and also these other surveillance data sets. And finally, this is an index where we could have waited until all the evidence was out in terms of which factors are really matter for COVID. But we felt we had to get something out based on the evidence available in March 2020. And we've updated it since as new evidence has come out. Okay, so not all the detail here is important. Just to say that we ended up with an index that has 7 themes, 3 of the social themes and then 4 related to health factors. And it contains 40 indicators, not all of them at the census tract level, but at various levels of geographic precision. And the main things we added were epidemiological risk factors. So in a census tract, how many people are estimated to have comorbidities like obesity or hypertension that are known to aggravate a COVID infection and raise your risk of getting hospitalized. How strong is the healthcare system in terms of funding, capacity, performance? High risk environments, things like we counted up, for example, how many people live in nursing homes in a particular county, how many people, what's the size of the prison population, what are the high risk work environments like meatpacking, and finally a factor on population density. And that was more pragmatic than anything else, because a lot of the partners we work with were keen to have that readily available as they were looking through the data, to know, where are the dense areas and the less dense areas. We know that the virus can spread a little faster in dense areas. So that's why it was in there. And again, the whole point is not necessarily that you have now one overarching score and that's all you need, right, to have an effective response. The point is that you now have to your disposal these 7 themes, and even where necessary, these underlying indicators. And depending on what area you're looking at, right, if you're planning an intervention for health or to improve the economic conditions or education or food security or these kind of things, you can pick and choose and understand the environment and the context you're working in a particular county by looking at parts of this index. So yeah, it's really not a one-stop solution where you now have one score and it tells you everything you need to know. It just helps provide context to all this other data that's coming out. So this is the index, and every county in census tract is giving a score from 0, which is not vulnerable, to 1, which is most vulnerable. And here we've just split that into 3, basically. So you can see most of the vulnerability, these high scores, are located in the south and in the southwest. And that's not overly surprising, and it's actually quite similar to what the social vulnerability index shows you as well. But like I said, what's more interesting is when you start breaking it down into these individual themes. So, we have minority status and language, which is actually higher vulnerability in the southwest with large immigrant populations. We have high risk environments where the Midwest has relatively high vulnerability. Epidemiological risk is, again, not quite concentrated along the same lines as socioeconomic status. So what you end up with is, for every county or census tract or state, you end up with a profile, a vulnerability profile, that's with how it scores on each of these 7 elements. And based on that profile, you can then consider look at other data and how you might respond to that to mitigate the impact of COVID-19. Now, I figured this was a data science crowd, so I should at least say something about how we implemented this. I don't think it's necessarily very spectacular, but I thought I'd share anyway. Just to say, we sourced public data, and it was mostly public data that's in the index, but also some restricted access data sets, particularly on epidemiological risk factors at a high geographic precision. Those 40 indicators are then aggregated into sub-themes and themes and an overall score using a series of percentile ranking, where you rank an indicator across all the counties, for example, and then you sum them up into a sub-theme, you rank again, sum them up, and it's a series of computational steps like that. It's pretty simple. You could also do something like Z-score or other approaches, but we use percentile rankings, just like the social vulnerability index. And that's all implemented in R, runs on an EC2 in the cloud, and we use GitHub for version control, and the project structure, in case anyone cares about that, is project template, which, if you're from a Python background, is a bit similar to cookie cutter data science kind of structure. And we use that for all of our projects. Now, maybe a little more interesting is that once you have your index and the data frames associated with that, we push it to 2 places. The first is a database on AWS, a high-performing database that is connected to an API that's hosted on EC2. So if you, on your phone or your laptop, go to our website, then you make a direct request to this API, which serves up the data so that it's shown on your website. And then we also have an internal database that we use to access the various data points. Maybe I'll take a question here. So how do we weight different indicators when constructing the index? That's a great question, and a subject of never-ending debate among those that build indices. We use an implicit weighting structure. By that I mean, if you look at these themes, some themes only have a few indicators. So those indicators are relatively heavily weighted in the overall index. whereas other themes have a lot of indicators in them. So each of those indicators relatively has a smaller weight. We didn't apply any explicit weights. And that's partly because we're building an index for a range of outcomes. So you could optimize the weighting in your index, say for COVID-19 mortality, but you'd probably be making it worse for something like economic outcomes. So we didn't end up doing any explicit weighting. Other indices have produced multiple versions of the same index with different weights depending on what outcome you're looking at. Something we've briefly looked into as well, but it's not something that's been particularly sort of high up on our list as adding too much value. And honestly, when you do, we have created a few versions with different weights, and you end up with highly correlated indices anyway. So in the grand scheme of things, it doesn't matter so much. And in terms of the question on how generalizable this is to other countries, I'll talk a bit about that as we talk about Africa as well. And then one question on geographic units of input data and resulting indicators, I think. So the question is, the data that comes in, all of these indicators, how granular are those data? And they're very granular for some at the census tract level, but for others, either the data isn't available at the census tract, so we just use the county value, or it doesn't make sense to express it at the census tract, right? If you're saying the strength of a health system, that doesn't exist at a census tract level. That's something that maybe exists at the county, or in some cases even at the state level in terms of funding. It's a mix of different indicators at different geographic levels, but the same ones at each of the levels. Okay. So back to this point we have our internal database that we use and then a public facing website. We also have a large sort of range of public data sources that we pull in every day. So these are things like cases and deaths, but also now vaccines, and there's a large-scale survey from Carnegie Mellon University, very impressive project where they survey thousands of people, tens of thousands of people very regularly, and get very fine-grained data on that as well. We have organizations like GIS Core, which is again a very impressive sort of crowdsourced organization, which maps all the test sites and now vaccination sites as well. And there's more as well. We pull that all in, and then we spread that out across our database as well. And a lot of that is served up on our website as well. Right, so the outputs of that, we fairly recently released a report on the damage done to these vulnerable communities and the way forward, that basically looked back at last year and said, what has been the differential, the inequity and impact? And here is some of the highlights in terms of the direct COVID-19 impact. And this is actually pulled live from our website today, and this is updated daily. So we felt it was very important not to just after the fact, months down the line say, look at these poor vulnerable communities and the impact. We wanted to start tracking live, what's really happening and what is the inequity. So here, for example, just in the past week, literally the past 7 days, the people living in the top third of vulnerable counties, they've been a little bit more likely to have been diagnosed, and they've been more than twice as likely to have died from COVID compared to those less vulnerable communities. But they're also 20% less likely to have been tested, just in terms of the number of tests being performed, per 100,000. And they're a little bit more likely to be a hotspot. But these numbers vary day by day, and it's very interesting to track. We also show the numbers over the entire course of the pandemic, and they're no less shocking. So especially people in vulnerable communities, the mortality rate there has been 44% higher, which is just an enormous number and goes far beyond small differences in age and comorbidities. Again, much less likely to have been tested as well, more likely to have been hotspots. And this is, so we give these high level numbers. We also have this more deep dive interface where there's a lot of different metrics you can track. And again, it breaks it out by vulnerability as well. So for example, average distance to a test site. If you were to scroll down here, you would see that same metric broken down by vulnerability, and you could look at by state as well. So there's a lot of data here, and it's all focused on surfacing patterns around inequity, around vulnerability. I know there's a lot of dashboards out there that show sort of regular surveillance data. This is really about inequity. And we're currently working with a lot of different partners. from the CDC and state health departments to some companies and other foundations to leverage the CCVI, make sure it's used in the right way, and make sure that our work is translated into action on the ground. Well, maybe that's a good point, actually. There's one question about commercializing indices. I should say that we're not a company, so we're a non-profit. So we make the index is readily available online. One second. The index is freely available online. So in that sense, anyone can use it. We get our funding through funders and donations. Okay, so just a few graphs to further highlight the inequity. So remember, I just showed you that number of 44% higher mortality. We can track that number over the course of the pandemic, right? So what is that inequity over time? And it's not at all constant, right? So you see any numbers above 0 means that the people in vulnerable communities are dying at a higher rate than people in low vulnerable communities. And, the 100% is here. It's quite low on this scale, but 100% is shocking, of course, right? It's twice as likely to die. And you can see here around the summer, when actually cases were a bit lower, inequity was greater, over 400% difference, so more than 5 times as likely to die in high vulnerable regions. And then in this winter surge, where the virus just spread relentlessly throughout the country, actually inequity was fairly low because every county was just being battered, really. But now, as this winter wave is receding, we see that it recedes much faster in low vulnerable counties. So we see again this inequity rising, and it's over 100% again at the moment. I'll get to that question maybe after these. Yeah. There's also another, like I said, we're not just interested in COVID mortality, right? It's a very worthwhile metric, and with over 500,000 deaths in the US, it's something that we need to look at. But there's also many other outcomes that affect the well-being of people across the US. One is, for example, unemployment. So we saw that unemployment shot up across the country, but more so for highly vulnerable counties. And again, it's actually recovered quite well, but much more so in these medium and low vulnerable counties. There's still a large gap here with high vulnerable counties having high unemployment that just wasn't there before. So these places have really been hit hard. And if you then look at, this is mortgage payments. So what percentage of homeowners are behind on mortgage payments? And you see the exact same pattern if you're looking at rental arrears. You can see that these high vulnerable, this I believe at the state level, so it's a little less accurate in terms of the geography, but you can see people in high vulnerable states. In August 2020, they were more likely to be behind on their mortgage payments. And although the gap hasn't really grown that much, we're now close to 15%, close to 15% of people that are behind on their mortgage payments. I think with rent, it's even over 20%. So there's a real crisis looming there. And at the moment, there's a lot of eviction moratoriums. So you're not allowed to evict people in most states. But how to back out of those policies without a lot of people ending up on the street is a major challenge, also for the current stimulus. Okay, just to explain what the role of our data scientists have been, because you might wonder, where does the role of a data scientist or research scientist, we often call them, where does that end, and where does the role of the program managers and communications people start? Well, the data scientists do all the regular data science work that you might expect, but we also have to write documentation for, maybe people that haven't done PhDs for years, and that might be at state health departments or county health departments. So for analysts and those kind of people. We write reports that really focus more on the implications of the work and not on the data science or the statistics. And that's largely done by our research scientists. So you really have to be engaged with those implications. We do press releases and we raise awareness. Those things are always on tight deadlines because things often become irrelevant. And similarly, then you get requests back from journalists, and then they need a response 3 hours, sometimes even generous. Sometimes it has to be even quicker than that. So this is, by the way, all of this is not at all to boast or anything. I'm trying to, I guess, paint a picture of, if you want to do data science in an organization like ours, you just have to have a slightly different set of interests, and you have to find this enjoyable, right? And that's not for everyone, which is totally fine. But if you just want to do data science and not sort of worry about some of these things, there's plenty of people that have that, and that's fine as well. But I'm just trying to, I guess, paint a picture of what it'd be like at Sergo as a data scientist. The other thing is presenting non-technical decks to stakeholders. Would you enjoy spending like a couple hours a week presenting to non-technical people about your work, right? And really understanding their needs and understanding how your data products could be different and better to suit the needs of these people. Again, really enjoyable if you like that sort of thing. Otherwise, it could become a drag fairly quick. I think one of the things I've learned over the years here is that there's this comfort zone for data scientists, right? So we like to talk about data analysis and stats. Basically, all the things that stakeholders care absolutely nothing about, right? So they care about what are the implications of your work and what are the solutions? What do we need to do? And yeah, you have to, as a data scientist, you can't rely on your colleagues to make that leap from the stats to the implications. So the scientists that I work with that are at Surgo, we spend a lot of time worrying about this side of the equation after getting this right, basically. And again, that's not for everyone, I think. Yeah, and then, okay, I'll switch briefly to vulnerability in Africa, because in spring of 2020, we took the concept of vulnerability and kind of build it up from scratch again for Africa, because we felt it could be a valuable tool there. To kind of illustrate that, I want to launch a little quiz. So if you're on Zoom, you can, in a minute or so, in 10, 15 seconds, you can give an answer. And I'm curious to see what people are going to say. Basically, I want to ask each of you to estimate or to guess, how many days does it take the United States to perform as many tests, right, COVID-19 PCR tests, as Nigeria has done during the entire pandemic after correcting for population size? I'm going to try and launch that. Let me just see if I can do that. Bolts. And then I'll wait, 15, 20 seconds. Here we go. So no peeking. All right, you've got 5 more seconds. Okay, I'll end it there. Oh, yeah. So I'm going to share the results with you now. I think you can see this now. So we have about a split between 1 and 3 and 4 and 7 days. And then some people are guessing 7, 14, and 14 plus. That's really interesting. I had no idea what was going to come out of this, but it's fascinating to see. The answer is that it takes 2 days. Nigeria has done 7.5 per 1,000. The US is doing currently about 3.5 per 1,000 per day. And then if you look at the UK at the moment, they're testing like crazy. So they do it in 20 hours. They do as many tests as Nigeria has done in over a year. And then just for reference, South Africa was actually doing, kind of the best performing country in Africa of the large African countries. It takes them about 2.5 weeks. Yeah, so thanks for sharing your estimates. It's fascinating to see. Just to dive a little bit more deeper into that, right? So if we look at Nigeria and say test per 1,000, I just told you 7.5 per 1,000. The US has now exceeded 1,000 per 1,000. So it's 136 times higher in the US. Similarly, cases per 100,000. So the case rate is also a lot higher in the US. And then the mortality is also a lot higher in the US. Of course, this raises the question, well, if Nigeria tested more, would they have had similar rates of cases and deaths? I.e., are there that many cases and deaths in Nigeria? And basically, my point is that we don't really know. There's many reasons to think that that's not the case, that we don't have as many deaths and cases in Nigeria. Because not only are the testing rates very different, the age structure is entirely different as well. Nigeria is a very young country. The kind of spectrum of comorbidities that put you at risk of hospitalization and death, very different. It's different policies. They instigated a travel ban very early, or a lockdown very early, before a lot of the virus had been seeded. The culture is different, so there's a lot of differences, and a lot of them are written about this. But nonetheless, in Sudan, another study had been done that estimated what number of COVID deaths had actually been recorded in official statistics. And they found, using a range of techniques, and this was from Imperial College and Harvard as well, LSHDM, a few different reputable organizations, they estimated 2% of deaths due to COVID had been reported in official numbers, which is, it's just a very shocking number. And it makes you wonder about what we still don't know about COVID in Africa. Similarly, I'm not going to spend too much time on this, but you can see that rates of testing, Nigeria is here, but it's low across most of sub-Saharan Africa. So what we did was we felt like, well, already then it was clear that there was going to be very limited testing. Like, well, what can we do to get ahead of that, right? What can we do to reduce and mitigate the impact of COVID-19 in the absence of high quality surveillance data? So we built an index that was Africa-wide, is subnational, and is COVID-19 specific. The subnational is very important because there's a lot of national indices that say this country is prepared or not for an epidemic or has a good healthcare system. But if you're in the government of a country, you want to know which regions of my country do I need to intervene in or do I need to work in. So I'm going to go over this just in the interest of time fairly quickly, but we did literature research on Africa, built an index particularly from the ground up based on 7 themes. Some differences are, for example, fragility, like food insecurity, civil unrest, and end up with a vulnerability index for 48 countries. Here we're looking at Nigeria that we were just talking about. And you can see that the north and northeast are vulnerable in Nigeria. Now, to anyone familiar with Nigeria, that's not a surprise. What's more interesting, again, is when you break it down into these themes, and you can start to look, well, if I want to know, where there's a lot of age vulnerability, I would look in the southwest, civil unrest and food insecurity in the east. So you can really look at, depending on the questions you want to ask and the interventions you're considering, beyond COVID, right? Financial support, agricultural support, food support. You can start to use this index, and we're working with the Nigerian government on this, and also on some questions around vaccine distribution. Okay, so let's switch briefly to the US vaccine rollout as a final part of this talk. We developed a portfolio here that this started in autumn last year, and it was really around how can we support the vaccine rollout and ensure widespread coverage and a rapid rollout. So this includes the vulnerability index that we talked about. We developed yet another index. So this was our third by the time. This was specifically around issues around coverage, health system, but also how many people lack access to healthcare, don't have a regular doctor, for example. Where do we see historic under vaccination? Where do we see socioeconomic factors that are predictive of vaccine uptake? We have a vaccine allocation planner, which I'll tell you a bit more about. And we have an ongoing effort around vaccine uptake solutions. This is around surveys, perceptions, hesitancy, and what messages can we use for different subgroups of the population. But I won't be talking about that today. So just on the vaccine allocation problem is that late last year, we had the government putting together recommendations about who should go to the front of the queue and who should, whose turn is it after that, whose turn is it after that, right? Who's going to get the vaccine first? We weren't going to sort of get involved in that discussion, but we could see that there's still a lot of work to be done even after you've set that order. You need to know where these people are, and you need to know the overlap between these groups. So let me tell you what I explain, what I mean by that. So we have the CDC committee putting together these groups, right? And states can follow that order, or they can do something else. But we were going based on these groups for the time being. Healthcare personnel, people in nursing homes and similar conditions, frontline workers, old people, slightly less old people, etc. So we collected data on each of those groups at the county level. So we wanted to know for every county, how many people are there that fall into each of those groups. But then you're still faced with a problem, which is there's a lot of overlap. So if you're saying one group is older adults, one group is people in care homes, and one group is the severe comorbidity, there's a lot of overlap. People in care homes tend to be old and tend to have severe comorbidities. So you end up double counting or even triple counting some of those people, meaning you would send too many doses there if you were just going off these raw numbers. So in the interest of time, basically I'm going to say that we work with Ariadne Labs, who have been a great partner throughout this, and particularly with Kate Miller, who did the work in estimating these overlaps and coming up with a very clever algorithm to do that. And I would encourage you to invite her at some point to speak, because it's really been an impressive piece of work. The point being that at the end of that, we had an estimate of the overlaps and the size of these groups for every county in the US. And we put together this tool where for any state, you could say, I want to vaccinate particular subgroups. It would tell you the size of those groups and the overlap. So you're left with a net size of that group. And it would distribute a certain number of doses available across counties based on where each of these groups are. And you can also, another feature not shown here is that you can redistribute some of the doses to more vulnerable counties based on our index or that of the CDC. That was also a national recommendation at the time. So it allows you to redistribute to accelerate these vulnerable places. And these same data were also featured in the New York Times, which kind of, I think also bred some sympathy for people in front of you in the queue, right? So you could enter how old you are and what your features are, and it would show you where in line you were, both nationally and in your state. Okay, so just to wrap up, I think, and then we'll do some questions as well. I guess I just want to explain the kind of style of data science that we do. Like I alluded to this earlier. There's kind of this consultancy style of data science where you're trying to solve problems with partners rather than build products and retain users, for example. So one is a focus on communication and usability. And I think we really pride ourselves on doing that well so that what we build actually ends up in front of the right people and raises the awareness that we feel it deserves. So for example, where you might be spending 80 to 90% of your time on data science, in other places, at Sergo, you might dial it down to 60% and spend more time on the communication side. A second point is this focus on the so what. So like I said, you always have to think about the implications of your work. What does it mean for the stakeholders? What are the real world implications? And like I said, it's sometimes beyond what data scientists are comfortable speaking about, but it's very important nonetheless. It's also an element of creativity about solving problems within your projects, but also seeing the bigger picture. Our work is very collaborative, so you're hardly ever working by yourself on a project. And that sounds fun, but it can also be hard, right? Working with other people's code. You have to keep some of the less technical people on track, managing the overhead of doing collaborative science. But also you learn a lot from others. You get to do code reviews, journal clubs, you learn best practices from others because we have researchers from so many different fields. And finally, the work is pretty fast paced. And again, it's not a boast, that sometimes it's frustrating, right? You want to spend more time on an algorithm, but you have to just go for the simple solution rather than the perfect solution. And a good friend of mine recently wrote, you can publish a paper by solving an easy problem with complex methods. You cannot make money by doing this. And I would say, you can replace money with impact there, right? So no partner of ours will be pleased to see a simple problem they had solved with needlessly complex approaches. Okay, so I'll end it there. I just want to thank the whole Surgo Ventures team who've just been amazing throughout the whole pandemic. All the partners, collaborators we work with. I'd encourage you to check out our websites. Precision for COVID is where a lot of our COVID work is shown, and Surgo Ventures is where we have our general organizational website. And I'd also like to thank our funders. So I'll stop briefly there, and then I'll have a look at the questions as well. So Jennifer, is there anything you want to, should I just have a look through the questions and answer those?
Yeah, I think if you want to take a look and see if there's anything that you didn't address yet.
Sure. Great, there's a question about the Africa index. We didn't write a report on that, but if you look on precisionforcovid.org/Africa. There's a whole, the index is shown there interactively with details on the methods and all the country level details. There's a question on if you use spatial mediation models to capture geospatial confounders. No, we didn't do that. We didn't end up doing a lot of, the analysis we ended up doing, for example, relationships with mortality were pretty straightforward in terms of being regressions. We might do mixed effects models where we add state level intercepts, right? So we're looking for relationships within states rather than just capturing differences between the south of the country and the northeast of the country. So we didn't end up doing any spatial mediation models just because it didn't seem necessary. But yeah, if you have any ideas for that, please reach out or write up another question. Yeah. So Chad asks if we've been surprised by ways partners have used the indices or notable applications that you didn't expect. Yeah, for sure. There was one, for example, one was about, I think it was a Vanguard charitable fund, and I think they used the index to kind of direct their people to donate money to communities most in need based on our index, which was very interesting. And unrelated, we had another organization reach out that used to deliver pizzas to people in polls. And they were wondering if we had any data because they wanted to deliver pizzas to people in vaccine queues. I don't think we were of much help to them, but there's definitely been just so many people getting involved in the COVID response. Question on the backgrounds of people on our team, whether they're all PhD. No, definitely not actually. Among the data scientists, I would say they're probably 60% have PhDs, but there's also people that have worked programs in developing countries as analysts and worked their way up from there. We have people from Silicon Valley who've worked in tech companies there. So it's a mix of people really. And that's kind of what we need, because when you're in a relatively small organization, you want lots of different ideas, right? You're always kind of reinventing yourself as where should we be going next? Where can we have impact? So if you have too many people with similar backgrounds, then yeah, you kind of narrow yourself down too much as well. Question on the availability of the indices, whether we intend to extend it to other regions. Yeah, they're freely available on our website, precisionforcovid.org, so you can download them there. And we don't have plans to extend them into Europe or East Asia at the moment. We are working in the UK to do a similar exercise in terms of understanding the differential impact on vulnerable populations compared to less vulnerable populations, but that's in the UK. Okay, about commercialization of the indices and related Sergo products. Yeah, sure. Maybe it was a bit quick there. So maybe let me just explain Sergo as an organization. So we're a non-profit, meaning we don't really sell what we do, right? We raise money through funders and foundations. But when we work, for example, with the government in India or Africa, we don't charge them for our services. We might work together to raise funds elsewhere, but we don't really charge for our services. So what we're looking for generally are collaborations where we can have impact. So, we reach out to, like I said, large government bodies or foundations or health programs, and we work together to implement the index. Yeah, and there's no exchange of funds or anything, so there's no commercialization in that respect. I feel like you're kind of batting away. It's like they keep coming at you, and then you keep batting them away. It's fun. Yeah, so any variables missing you wish you had to include in future index work? I mean, less so in the US. I think in Africa, it was a real struggle. So in Africa, there's a lot of data at the national level, and we worked really hard to get the subnational data and get it for as many countries as we could, doing even many countries individually. So I think there, in Africa, for example, one enormous problem is the lack of data on non-communicable diseases. So there's obesity, but if you're talking about hypertension, or cardiovascular disease, especially at the subnational level. There's a real deficit, and there's a lot of very smart people working on that, but that's one thing that's so critical for COVID, and at the same time, there's just so little data on it. I don't know, Jennifer, how are we doing for time? I've got one more poll that I'm selfishly curious what the responses are going to be, but I know we're...
Absolutely can. Yeah.
Yeah, you sure?
Sure.
Okay, so if you, I'm gonna, hopefully I've built up a bit of goodwill, and I'm about to, about to expand it. So I figured I don't get a chance every day to have like a data science audience in front of me. So I want to launch a little poll. This is about your coding habits. And then I'm going to talk a bit about those coding habits. So let me see if I can launch that here. The questions speak mostly for themselves, right? I use version control. This is about reproducibility, which is, I think, also a hot topic within the HDSI. So can you easily reproduce with the run of a script the figures that go into your paper, the numbers that go in, or is there a lot of manual work involved, and some of your coding habits? So I'll launch that now. Go. Okay, off you go. All right, we're at 35% of 40 now. Okay, we'll give it another 10, 15 seconds. So Zoom polling is pretty neat, but it doesn't allow you to disaggregate the data when you show the results. So we're going to have to kind of manually do the calculations to get out the people that don't code. That's okay. Okay, we can end it there, I think. Okay, let me share the results. So I think you can all see that. So let's go through together. So this is about half the audience. So we have about half the people that code, about a quarter that don't code. Half the people that use version control, a quarter that don't, 1% doesn't know version control, and then 20% that don't write code. Okay, so that's the majority, but still a substantial portion. And then going to the next one, how much of your work is easily reproducible, right? And for context, the computational reproducibility, which means you can give me your scripts and your data, and I can reproduce the key work that you've put out, like publications. It's a very, rightly so, it's a very important topic. Excuse me. And my answer here wouldn't be 100% either. Like, it's very hard to reach 100%. But there's reasonable reproducibility. Some people maybe a bit less, but I think we're all getting there as a field. And then these questions are a bit more detailed. This is about whether you write tests for your code, right? Tests are like automated checks on whether your code is right, and whether you have your code reviewed by your colleagues. So the rates are fairly high, especially once you take out the 27% that don't code. That would boost it by about a third or so. Okay, so let's have a look. So I'll share you my thoughts, and I'm curious to hear any of yours. This is basically the sort of stuff that keeps me up at night, right? So like you've seen, we work with so many messy data sets, right? Public data sets, private data sets, and we combine them, and there's a lot of pre-processing. Like every data scientist, there's a lot of pre-processing. Reproducibility is very popular, but coding is really error prone, right? So are we just reproducing each other's errors? And it's extremely labor intensive to check someone's entire code base. And I don't know how many of you know this, but it's often kind of estimated that there's one bug per 20 to 50 lines of code. Let's take the generous estimate of 50 lines of code. If you write 100 lines, there's a 13% chance it's bug free. If you write 10,000 lines, say an average PhD, maybe, there's no way it's bug free unless you put in some really, really strong kind of checks and balances there. So actually, when I told my mother about this, who's a retired engineer, she said, oh yeah, when we used to work on spreadsheets, we'd have this thing called Rainbow Analyst. And it would audit your spreadsheet. It would check for inconsistent formulas and numbers that didn't make sense or formatting issues. And it would give you these little reports. So that kind of brought home to me, like for all of us working in R and Python, MATLAB, Rust, all these code-based analysis tools, where is our Rainbow Analyst, right? Where is our automated tool that checks our work? And there really isn't. So we need all these extensive systems in place, right, to reduce and not even eliminate, but even to reduce error. So we have to write tests, which we should be doing a lot more of as a field. We have to review each other's code, which is time intensive. Pair coding, we sit together behind a computer, one screen, working together. And also at Sergo, we do a lot of this, but it's such a barrier to entry. It kind of worries me that in data science for research in particular, we're pretty far behind the curve in terms of the quality of our code. So this is something that we're kind of pretty concerned about at Surgo as well, and always trying to improve our game. So I have this fairy tale dream that, instead of writing code just from scratch where we have to write our own tests all the time, aren't there any better tools out there where we can much more quickly, much less error prone do our pre-processing? And there are those tools out there where you click and drag data sets and you join them and it warns you if you're doing really stupid things, but they're very locked in, they're extremely expensive. So yeah, I have this wish list of things I'd love to see in a data pre-processing platform where you have this, this user interface, it's open source, it's transparent. There's all these things happening in the background that are checking the work that you're doing and making suggestions for improvements. It's kind of human in the loop suggestions. If you're doing crazy joins or you're doing anything like that, it's version controlled. You can export it to code. You're not locked in. Anyway, this is like a fairy tale dream I have. If you know about this, please put it in the chat right now. Or if you don't, maybe start a company and tell me about it. As a final point, there's this AutoML, right? So once you have a clean data frame, there's all these tools out there to automatically fit your machine learning models. And again, I just worry that we're putting in buggy data, and that we need a kind of auto pre-processing that really improves our work and speeds it up there.
All right, Peter, maybe we have time if there's one last question you want to answer. Let's see.
Let me just check. Shuning, please do reach out about that point. I'd love to talk more about it, about the spatial autocorrelation and how we should be taking that into account. That'd be really good. The satellite images to predict health outcomes. We did a bit of this, trying to extract features from the built environment to see if that was predictive for health outcomes, for example, neonatal health. That was based on a science paper showing you can do that for poverty, which is a bit more straightforward, right? So you can predict poverty based on satellite images. And so you extract features from satellite images and then you correlate that with, or you build a predictive model for for indicators. There's actually been really fascinating work, I'm blanking on what country it was in, where I think part of that same team used satellite images to support COVID-19 resource distribution. I don't know if this was Eritrea or it was an African country, but I'm blanking on which one. But they used satellite images to understand where are settlements and particular people that are more likely to need support for COVID-19. And they worked very closely with the government over many months to help distribute resources. Sorry, I'm blanking on who did that, but it was fascinating work. I'm sure you can find it on Google.
All right, then. Okay. So thanks, Peter, for that really excellent talk, and thanks everyone for your questions. Our next industry seminar is April 15th with Juan Lavista from Microsoft's AI for Good Research Labs, and we'll hope you'll join us then. And with that, I think we'll say goodbye and see you next time. All right, everyone. Take care.
Thanks so much, everyone.